Matthew Holt, the Healthcare Blog, back with another Spotlight. I'm talking to Brooke LeVasseur. She is the CEO of AristaMD, based down in San Diego. And Brooke, Arista is one of the sort of relatively new, not that new a company, but a few years old now, and you've been CEO, I think, for 3 years, is that right?
Coming up on 2.
Coming up on 2, so 2 through who's counting. And you are in the business of asynchronous eConsults, which is, I guess, a very specialized small slice of the kind of telehealth remote consult market. Can you explain a little bit about why there is an eConsult market and why it needs a specialist company?
Yeah, absolutely. So first of all, thanks for having me.
Of course.
Happy to be here talking about what we do at AristaMD. So we are in the eConsult space. Really, the mission of eConsults is to empower providers to get patients faster access to care. There is a huge problem today with getting patients in to see a specialist in a timely fashion. There are a bunch of reasons for this. You know, we have a large aging population and we have a huge shortage of trained specialists. And these things are coming together to mean that patients are waiting for often weeks or even months to get in to see a specialist and get the care they need. E-consults are a really efficient way for primary care providers to tap into the expertise of specialists and get recommendations on care plans in a matter of hours to immediately start executing on a treatment plan without that patient having to wait and to travel to go see a specialist. So that's what we're all about.
Very good. So give me a rough guesstimate. How many referrals to specialists never happen? Forget your business for a minute. I go to see a PCP. The PCP says, oh, you should go and see an endocrinologist, anesthesiologist, whoever the specialist is. Yeah. Anesthesiologist is unlikely, but possible, I guess. How often do people just not show up and not do that? How often does that thing fall apart?
It can be incredibly high. So in some populations, like Medicaid populations, that rate can be as high as 40% of referrals never get fulfilled.
That's a bit like, drugs never being filled at the pharmacy. So that's one reason we're doing it. And the second thing is, what's the average wait time for some of these specialists? I mean, I guess the Medicaid population can be very high, but in general, what's the access?
Absolutely. I mean, across the country, we're seeing average wait times of often 1 to 2 months to get into some basic specialties like dermatology. So, you're sitting there with a rash and you will literally have to go to the ED if you want that rash to go away because there is no one who can see you in a timely fashion.
Okay, so you're in that space between the primary care doc or the primary care clinic and the specialists, and you're kind of routing around that. In a minute, I'm going to ask you to show me how this actually works, but who are these referrals going to? Is that something that does AristaMD have its own panel of specialists? Do you work with local people in the area? Do you have a national panel? How does that work? Who are you routing to and from?
Yeah, great question. So the core of our solution is a web-based portal that transmits information. Now there's 2 different ways you can utilize this platform. One is to tap into experts that sign up with AristaMD to answer these e-consults in a matter of hours. So we do have a national panel of specialists that are on call. They cover basically any specialty that is not procedural and does not require hands and eyes on the patient. So it's a broad list of specialties that we can handle. On the flip side, you can license our platform. If you're a health system, you have employed specialists who are available to answer those e-consults, then they can be the ones fielding those requests from the primary care providers.
And roughly your business so far, how is that breaking down?
Right now, I'd say 90% of our business in our installed base is primary care clinics that tap into our own panel of specialists, but that mix is really rapidly changing as we're seeing a lot of large health systems start to adopt e-consults. So I think over the next 12 to 18 months, that mix will rapidly shift to be more even.
All right, well, interesting. Now, so obviously one of the things here is that you're providing a piece of technology that is part of the experience of the primary care doc and potentially the patient. I'm not sure how the patient interfaces with this at all. So I was going to ask you to tell me what happens, but actually I think I'll ask you to show me what happens. So yeah, I know you've got a bit of a can demo here, but let's take a look. So if you don't mind sharing your screen and just walk me through what happens. I show up, I have a rash, I have a kidney problem, I have whatever, I see my PCP, and they want to get an answer from a specialist about me. What happens next?
Sure, absolutely. Let me walk you through it really quickly. I'm going to share my screen. So what you're looking at right here is the main dashboard that a primary care provider would see when they log into our platform. It has their queue of eConsult requests that have come back and the recommendation that has been given by the specialist at a high level. I'll show you how to walk through it. So I see a patient, I think they might benefit from a referral, but I'm going to try submitting an eConsult first. I will just click on add a new request, and here they will have to pre-populate some basic demographic information about the patient. I've pre-populated one of the cases, but they'll go in and quickly type in this information, so patient name, date of birth, etc. Then they will submit the specialty area for that patient, and then they will choose the main symptom or issue that they want to consult on. Once they've submitted the main symptom and issue, a clinical workup checklist will pop up to the right. This has been developed, they're all condition specific, and they will drive the requester to know exactly what should be included in the case. So it will tell them what are the relevant clinical assessments or recommended labs and diagnostics that a specialist would need to see to weigh in on a case. They can then use this as a roadmap. They know exactly what to put in. They can type in some background clinical notes, patient history. If there are relevant lab results or photos or images that they want to upload for the specialist to review, they can just simply attach it. I'm just pulling it in here in the demo, but they would just pull this simply from their desktop. And then it's all set to go. From there, they hit continue, and our system will automatically route the case to the most appropriate specialist. We do this by looking at who's on the schedule, who has certain expertise in different areas. And we also have a rule that looks at whether that patient has already had a consult in the specialty. If they do, we prioritize that previous specialist for some continuity of care. They see the background bio, a picture, training, certifications of that specialist, so there's some relationship building here. And when they're ready, they'll hit submit. So very simple.
How long does it usually take the specialist to answer back? You're going to show us the specialist answering back, but how long does that usually take, roughly?
Yeah, so we guarantee the response in under 24 hours. The majority of our cases are actually back in 5 to 6 hours. So it's very rapid turnaround. The goal is to not delay any patient that does still need to get that face-to-face visit.
Okay, so show us the specialist viewpoint now.
Sure, so here what we're looking at is the specialist queue. You'll see the new case that's come through. They will click on it, and the information the primary care provider has put in will be summarized for them in a little bit of a different order. Background information first, and then importantly, what is the clinical question they're supposed to be weighing in on. They can view any of the attachments. We have a DICOM viewer in the platform to view all sorts of image assets. And then when they're ready to respond, they click on their consult, choose a high-level disposition. So there are a couple interim steps if they want to request more information. So an additional lab result, for example, they can request it here. But most cases are answered with the response saying this patient can be managed by you, the PCP, and they will outline the instructions for what they recommend as next steps. I've again preloaded this case, but the specialist would sit down and type in their recommendations. At the top there is a section where they can tell them if there's any additional labs or diagnostics that they should be running. The second section will tell them what they as the PCP need to be doing next. And then there's a section for the patient specifically. And lastly, follow-up instructions. From there, they hit submit, and they will be reminded that they have to sign off on this case. It will be an official documented part of the patient record. And from there, they submit it. Back at the PCP queue, the PCP will get an alert. They will go into the platform and view the case. Again, the high-level disposition will be up here on the right. Thumbs up, meaning this patient can be treated face-to-face, avoided the need for a referral. And I will say close to 75% of eConsults that go through our platform have this disposition and do mean that the patient does not need to go to that visit and can be treated more quickly. And then they can read through all the information. If they have any follow-up clarification or questions they want to ask, they can do so below. And then when they're finished, they can simply close out the case. Here's a closeout form. It's really important to us to capture data on the efficacy of this program and overall user satisfaction so we can monitor the success of our programs with our partners. So we have them tell us, did this strongly influence your care plan? did this consult actually eliminate the need for a face-to-face visit? And then they will rate us on a 0 to 10 scale on how likely they are to recommend us to their colleague. And that's really the end of the process. It's pretty straightforward.
Right, very, very good. You can stop sharing your screen. I assume that you discount any recommendations that are below a 10. I'm just so that looks sort of pretty simple. That's like a 24-hour, one-day turnaround. The patient's gone home. They then get the patient for the next visit gets a follow-up call or something from the PCP. However the PCP manages them, I assume they may get a call that afternoon saying, we don't have to get you a specialist, but here are the things I want you to do, or come back into the office their next visit. You said 75% of the time on your system it comes back as sort of managed within the system consult. Roughly how many office visits that would result in a special referral are you sort of end running? I mean, I assume the PCB goes, well, this one actually needs to be seen someone in person. This one probably would fit into AristaMD, but give me a sense about how that works.
Yeah, so what we know is that roughly 10% of primary care visits result in a specialty referral. And close to half of those cases are routine clinical referrals that do not involve a procedure and are appropriate for eConsult. So that's really our applicable pool. And the way we deploy at the clinic is to make sure that any of those cases go through a basic routing with those rules to see if it's not procedural, non-urgent, then basically it can be sent for an eConsult. So it's a very high percent of cases.
I get it. So that's, I'm going to do math on the back of my head here, which is roughly 1 billion and change office visits a year in outpatient, which means 10% of them, the 100 million are getting a referral. And that means you have 50 million visits.
Exactly.
I assume you're putting 50 million visits through the system now, right?
Soon. We're getting there.
Soon. Okay, well, let's talk a bit about that. How have you been rolling this out? This is a kind of interesting niche. There are people obviously doing sort of, live texting now. There's a lot of telehealth going on. There are some sort of asynchronous tools going from patients direct to primary care docs in the kind of the world, some of the world like hypnosis and some others like that, doing that. But there hasn't been much discussion, I think, apart from you and the folks at Rubicon MD around this sort of eConsult piece, which does sound like it's a major problem. So how have you been rolling it out? What's your business strategy from now?
Yeah, so, we have two primary clients. The first are health plans, who we contract with directly to cover the cost of the eConsults for their members. And then once we have those payers under contract, we will go out to the clinics and deploy there, and really the providers can use it at no cost to them. Payers do this because, number one, it's a huge cost saver, right? Treating the patient at the lower cost primary care site has massive cost savings, both in that initial triage of the visit, as well as by getting patients earlier care, you're avoiding a lot of downstream costs like avoidable ED visits and so on. So that's really where we made our start in this business. We've been on the market now over 3 years, and we made a lot of traction in the early days, specifically in managed Medicaid, where both the cost savings was compelling, but mostly for those plans, access was such an acute issue. Just finding a specialist who would accept a patient with Medicaid is so difficult.
Absolutely.
That this became a critical tool for those plans, and we've just seen that grow across lines of business now with our payer clients.
So just stopping there for a minute, give me a sense of which payers you're with, how many visits are going through the system, how many clinics are using it, and is there what's the sort of the level of effort required to get, I come with a free good for you, doctor, but is that cheap enough, when I actually have to roll it out in the system? Give me a sense of how difficult it is to roll it out.
Yeah, so the process of engaging payers is, of course, a long sales cycle for us. So it's a 12 to 18 month sales cycle. That never moves as fast as we want it to. But we now have major payers, including national payers who we're working with, groups like Blue Shield of California, where we're taking major regions, if not entire states, under that plan and serving their lives. The provider sale is surprisingly easy. I think the fact that they don't have to pay is one box, but you really have to prove to them that you're not going to disrupt their workflow and that you're not going to add additional work to what is already a very full plate. And I think that's where we've been able to excel over the last few years, is really coming in and showing them in a first meeting how seamless this is and how we can do this in a way that will only be additive to their practice. And so we see a very high rate of engagement and adoption across all of these sites that we go to.
But I assume if you're replacing, I mean, I think it's probably more satisfying with it for the primary care doc because they're getting an answer back and can keep that patient within their current workflow. And right now, this doesn't have to be, it doesn't have to be integrated with the EMR. I don't know how often it is integrated with the EMR on that side. But I assume you are adding a little bit more work because they used to sign a form and say, go see this doctor and give a slip. And then that's where the 50% fallout or 40% fallout was. But now they're actually having to do something. It's not a lot of effort, but it's something. Did you have any struggle around that or not so much?
No, what we've done is in the clinic, we offload everything that I just showed you in our form, the curation of that consult and the deciding of who to route to an eConsult or to a referral. We actually train referral staff to do that. So the PCP themselves just submits a referral in their EHR as they always have done, no change to workflow. And then it's the back office staff that kind of handles that triage and curation and uses our checklist to submit cases. So what's nice is the only work that happens for the primary care provider themselves is when they get the recommendation back and they follow up the patient. And sometimes that can be a follow-up visit. Many clinics like that, or a phone call. But that's really where the additional work comes in.
Right. So how are you seeing this, and maybe you're not yet, but how are you seeing this being used with other different types of remote consult, either directly to the clinic from using telehealth or other types of referral, like, live telehealth out in live consults? Is it becoming part of a panoply of other tools being used? And does that have hints for where you're going as a company, or is it still pretty much the only tool they're using to refer out to specialists?
Right now, groups have a lot of point solutions that are not well integrated. And there's definitely a desire to integrate all of these telehealth solutions kind of under at least one workflow or a couple common workflows, but most groups are not there yet today. So what we're seeing is several of our clinics that do have video telehealth capabilities at the site will often use that as a way to follow up after any consult with the patient. And that's the most common way that we're integrated with those types of video, solutions. Other than that, I'd say there's plenty of fragmentation that still exists.
So it's at this stage, integration means workflow integration in the process, not so much technical integration between you and other technologies. Which is great because a lot of people don't have these technologies in the first place, and I know we're struggling to figure out all these places still struggling with EMR implementations and that kind of thing. Tell me a little bit more then about, so you mentioned one thing, which is getting involved with payers originally sponsoring this primarily for Medicaid, but also for others in this process with the goal of increasing access and reducing especially referral costs. Tell me a bit about the other side of your business. You mentioned providers and getting to provider systems, and I could think that within a bigger provider system, especially when they're scared of this term referral leakage, this could be a great tool. And we're seeing a number of other people come in with different approaches for referrals. Tell me a bit about that side of your business, who you're selling to, where you are in that process.
Yeah, absolutely. So what's been interesting for us is that it is a very wide breadth of different types of systems that have come to us proactively to seek out an eConsult solution. It's not just value-based systems or groups that are well into that transition into value-based care. It's also pure fee-for-service health systems that are looking at a better way to reduce wait times into the system in order to increase patient satisfaction. And to be able to better triage the referrals that come in so that the higher complexity, higher value patients are the ones that are sitting within the four walls of the institution, and those lower acuity patients can be treated out in the community with the input from their specialists through an eConsult. So we are
there ways that either in the sort of original model or in the provider model you talked about now that the specialist is getting paid for this eConsult, or is that kind of a free good done to reduce the amount of lower value / lower reimbursable specialty consults when they do happen?
Yeah, most health systems do find a way to reimburse their specialists for participating. Historically, it's been through RVU credits is usually what a system will use, although now we're seeing this begin to shift. So as of January 1st this year, CMS started reimbursing free consults, so they are paying both the primary care provider and the specialist for traditional Medicare patients, and other private payers are following. So I will expect over the next couple of years to see health systems and others start actually billing per the codes that have been established for eConsults to capture that fee for the time that's being spent by the specialist.
And I assume in the original model, there's some payment for the Medicaid PCP or whomever, but there's also a payment by the payer, the health plan, direct to the specialist as well. But presumably not as much as if they see him in person, I assume.
So interestingly, no. Most of the plans that we work with a few exceptions, do not directly reimburse the primary care provider today, and we've been able to get great adoption without it. I think to scale in a really meaningful way across the country, that reimbursement will be important, and so we're really thrilled with the precedent that's been set with CMS in reimbursing the PCP as well as the specialist, and I expect more plans to shift to that model.
But to be clear, the specialist is getting paid by the payer, I assume. Or are they doing it for free out of the goodness of their hearts? I assume.
Yeah, the specialists that are part of our panel, we pay them directly out of our fee that comes from the payer.
Right.
Today.
Okay. Well, you're now ahead of me because I'm going to get up part about your business. So first off, how do you get paid?
So we will contract with payers either a per eConsult fee or a per member per month fee, and it's really up to the plan which model they use.
And on the provider side?
And in the health system side, it's typically a system license, and they will just pay us annually for access for their specialists and their PCPs to our platform.
Very good. So let's talk a little bit about AristaMD, the company. Tell me a bit about some numbers. So I know you raised some money a little, way back when, then you became CEO and you raised a bit more. Tell me a bit about the money you've raised.
Yeah, we've raised just over $20 million to date.
Okay, and then where are you sort of scale-wise? How many employees do you have? How many provider systems / providers are on the system? I don't know how you count it. What are the metrics you like to talk about as to where you are in terms of number of users on the system, and then tell me a bit about growth.
Sure. So we've got 30 full-time employees today, and growing over the next couple of months. We're adding over the next few.
You want resumes, I assume? I don't know. You tell me. This is your chance to say you can email me your resume kind of thing.
Yeah, exactly. We are hiring salespeople, so go to our website, look for listings that are open right now. We're now in 34 states with our users. We have several thousand users that are on the platform. And, what else can I say? We have a couple health systems working with us today, and that will be changing over the next couple months. That, as I mentioned, that part of the business is really going to grow. And, what else can I tell you? Thousands of eConsults coming through the platform every month.
Yep. And then thinking about this future, I kind of hinted at this earlier as to what other kind of stuff there is. If we're moving from a world where everything was face-to-face, I call this Indu, Sabaya, and me, when we write this, we call this flipping the stack. And you're somewhere in that part of the technology stack that is now becoming the sort of the bottom part of the pyramid, or the middle part of the pyramid rather than the foundational, just face-to-face visit. If you're replacing what was, face-to-face with technology as part of that sort of remote consult, what else, if you were to push the boat out, and whether this is you as part of some other organization or some other tools or products or organizations as part of your organization, what else do you think, as this becomes more prevalent, are going to be the next areas that you can see more? I mean, eConsults is one part. What else do you think is going to be included in that is going to be necessary for doing business if you are a primary care organization delivering care in the new era? What other kinds of technologies and products do you think will be along with an AristaMD?
Yeah, well, I think, as we continue to shift more towards value-based care and there's an increased emphasis on primary care, really giving those PCP clinics the tools they need to take on risk is going to be important. And so part of it is just managing downstream costs. So referrals, reducing unnecessary expensive referrals will certainly be part of it. a lot of what's at the crux of what we do is just matching the right patient with the right provider in the right setting. And it's happening in a limited way now through us, through routine consults, but you can see how that concept can be applied more broadly at the site, where you're stratifying patients and really matching them with the most appropriate, most cost-effective and efficient type of care based on their particular specific needs. So tools that help stratify these patients, track them and match them with the right care over time, I think will be critical. And finding ways to free up primary care capacity. So there's already a primary care shortage, and we cannot just continue to burden them with more. I know there's a lot of promise being talked about with AI and implementing that at the primary care site. I think we're farther away than we wish we were on that. But looking at tools that can increase capacity and efficiency for the primary care provider will be incredibly important for them to realize the promise of these, capitated contracts that they're getting into.
Fabulous. No, I think that's a great answer. Very interesting point. Finally, before I let you go, as there has been some controversy about this issue, you are a person without a Y chromosome. And I just am sleuthing with your LinkedIn. You have an English degree from Stanford. Which how did your career progress so that you're now running a health technology company? And give me some sense about really why how we help the pathways for more women to be sitting in the seat that you're sitting in.
Yeah, it's a great question. So I really came into healthcare. Serendipity is what it was. After I graduated college, I ended up going to work for an investment bank in equity research. And by chance, there was an opening on the MedTech team. So that is literally how I entered healthcare, and I have not left since. I think what's been so crucial to my growth over the last 20 years and my progression and being able to now be CEO has had to do with the mentors that I just happen to be so lucky to be given. I've now reported directly to 5 female CEOs who each one of them took me under their wing and really gave me some of the most useful advice I've gotten and continue to kind of advise me as I grow into different roles. And I don't know how that happened. I think it started with the first, and then that network is, once you build that relationship, those networks are strong. And so one opportunity leads to another. And I've been able to build an incredible community of advisors and leaders I respect who are women who have forged a way in very male-dominated industries. So I think the more we can do to help that network effect and to mentor the people who we touch and support women with that kind of sistership, I guess, and mentorship over time has been important to me. And so that's something I try to do day to day in my relationships and in the people who are here at Arista.
Fabulous. I'm hopeful by the end of my career I don't have to ask this question anymore, but it's important, I think, to get it out there just because we have all this glaring imbalance, of too many fat old white men like me sitting where you're sitting, and too many, not enough people of different ethnicity or genders, I guess, these days, what we should say. Anyway, all right. Well, thanks for that answer, Brooke. Thanks for taking the time to show us what AristaMD is doing. Really appreciate you coming on the healthcare blog, and I would looking forward to seeing more of you as AristaMD grows and changes in the future. I've been talking with Brooke LeVasseur. She's the CEO of AristaMD down in San Diego. I would say new, but a important growing player in the new-ish eConsult space. How about that?
Sounds good. Thanks so much for having me.
Thanks, Brooke. Pleasure.